get started with our webinar. Welcome to the New York City Community Health Center Geriatrics Education Project, which is a joint initiative between the Community Healthcare Association of New York State, CHCANYS, and the Geriatrics Society, AGS. Today's webinar is on managing the care of older adults with multiple chronic health problems. My name is Amy Sigelka from the AGS staff. Before I start the presentation, I just want to give you a housekeeping note. The team members are going to present for 40 minutes, after which we'll conduct a question and answer session. You can ask questions in the Q&A chat window on the right side of your screen at any point during the webinar, and faculty will answer your questions at the end of the presentation. If you have any technical questions or difficulties, you can also send me a message in the chat window at any point during the webinar. Eligible to receive 1 hour of AMA Category 1 continuing medical education credit for participation in this webinar. In order to receive credit, you must complete the post-test after this webinar is concluded. I'll review the details after the Q&A session. Now that we've done that, I'd like to introduce our speakers, Dr. Matt McNabney and Dr. Lori Jacobs. Dr. McNabney is an Associate Professor of Medicine and Director of the Geriatric Medicine Fellowship Training Program at Johns Hopkins University. He's the Medical Director of Hopkins Elder Plus, a program for all-inclusive care for the elderly. Jacobs is Vice Chair of the Department of Medicine at Albert Einstein College of Medicine of Yeshiva University, where she's responsible for clinical programs across general internal medicine and 14 specialty divisions. She also served as Division Chief for Geriatric Medicine for 14 years. In her current role, she works with 5 federally qualified health centers in New York City. So now that we've had the introduction, I'm going to pass this over to Matt and Lori. Thanks very much.
This is Matt McNabney. Hope everyone can hear me. Well, as was announced, I'm very excited to participate in the morning webinar and the application of what we've learned and developed in the care of older adults with multimorbidity and how it applies to your practices in the FQHCs in the New York City area. I think is a great opportunity. It's a visionary approach to providing care for complicated older people in urban settings, and it's a real privilege to share this with you today and to co-present with Dr. Jacobs. In a background, the topic is all people who care for older adults, even if it's not their primary focus, is well identified and is a struggle for all of us who care for older adults. When they have more than one condition, what's the best approach? How to approach it in the practice setting when you're dealing with lots of issues simultaneously. So that is the perspective we'll take this morning. So we have no disclosures. Dr. Jacobs will be exchanging the presentation back and forth as we intermix case examples which apply to your practices, and Dr. Jacobs will join in shortly after I give a bit of background. So the learning objectives are to describe the challenges and complexities of managing the care of older patients with multiple conditions, apply preliminary strategies for clinical decision-making in patients with multiple conditions in the FQHC settings, identify clinician support tools that can assist in the management of medically complex older patients. A hefty task for us as clinicians, but nonetheless one we face pretty much daily. Bit of background, older adults, over half of older adults, not something that's uncommon, over half of older adults have 3 or more chronic conditions, and most guidelines that we are familiar with and cite, of which there are many, deal with it from a single disease focus, and that's really the background that experts in dealing with multimorbidity came from. That's a struggle for us as clinicians, is to incorporate single disease guidelines into multiple disease patients. These folks have increased risk of death or institutionalization. It means placement in long-term care facilities like nursing homes or assisted living facilities. They're known to have increased resource use throughout the health systems. They receive care. They have lower quality of life than people who don't have multimorbidity, and increased adverse effects in dealing with those conditions. In translating that into what to do, the best approach for decision-making and management is quite unclear, at least up until the recent past, where people have started forging recommended approaches and the guiding principles which we'll talk about this morning into how to deal with this conundrum of care. A conceptual framework, you all probably address this in your own way in your heads, but on the left is how we traditionally tend to think of it. We have a diabetic patient who might have also congestive failure or also have hypertension, as opposed to an individual who has multiple conditions simultaneously occurring. So it really, these diagrams illustrate that we really can't focus on a single disease and how the other diseases relate to it and then move on to the next disease. There really is a simultaneous, concurrent management challenge. So with that background, we, within clinical practice models of care committee and the American Geriatrics Society, the committee that pushed this approach, brought in experts and sought the guidance and direction from our board representative, is actually Dr. Jacobs. The co-presenter is the AS board member who was the liaison for this committee and this effort. We crafted an approach which we called the guiding principles. Now you'll see on the slide an algorithm, or at least a progression of thoughts in how to manage people with multiple chronic conditions in a stepwise fashion. And we'll walk through these steps as we go through the rest of the presentation, but I wanted to illustrate that it is a systematic approach. You can, I believe, the task force that drafted these guiding principles, that it should be systematic, but it is perfectly appropriate and actually encouraged to individualize your approach. But the steps that are underlined in the pathway that shouldn't be overlooked. So just to highlight the steps in the pathway, when older people have multiple chronic conditions, it's important as a clinician to elicit the primary concern on. This is particularly true, and Dr. Jacobs will illustrate this. When you're seeing a person in the visit, what is their primary concern for that visit? Is it an overview? Is it a specific issue in a person who has multimorbidity? And the second box in the pathway illustrates that. Do we want a more comprehensive overview of care, or do we want a specific aspect of that multimorbidity situation in that patient? What about the current medical conditions does this particular patient have issue with? Is there an adherence that we've identified and documented? Is there comfort with the treatment plan? Next, we'll walk through in the presentation what are the patient's preferences. We think this is an important part that's frequently overlooked, and we'll illustrate that. What is the evidence regarding the treatment guidance, that condition that's appropriate for this patient or relevant to this particular patient? We think it's also necessary to consider the prognosis, both mortality or life expectancy prognosis, but also the functional prognosis, how that might impact the care decisions. What are the interactions within treatments and conditions that coexist within a patient? What are the benefits and harms of a treatment plan that might make a certain aspect more or less important? Communicating and deciding for or against the implementation of a treatment plan. Opening up the dialogue with the patient. This is what you as a clinician have come to decide is an appropriate plan. How does that sit well with the patient and the family? And then to importantly reassess at selected intervals with benefit, feasibility, adherence, and alignment with preferences of that patient. So these are essentially the core components of the guiding principles. We'll we'll go through those in this presentation. We'll also have a reference at the end of the presentation for you to go directly to the document that highlights these. So I'm going to, at this point, hand it over to Dr. Jacobs to discuss the case that we're presenting.
So good morning, everyone. I'm going to try to illustrate with some of the guiding principles that Dr. McNamee has identified for us. Our case today is an 87-year-old man who's complaining of fatigue and taking too many medicines. His mother and grandchildren also attend the FQHC for primary care, and he happens to be one of 4 older patients on your appointment list. And as many of you know, your list of patients for the day may be quite long, 15 or more patients. When you see a number of older patients, you may have that inner feeling of, oh my gosh, am I going to have enough time? His daughter, who comes to the FQHC frequently, his healthcare proxy, and she comes in expressing concern about his safety and his ability to live alone. He has Medicare, and he receives medications from the clinic at no or minimal cost, pharmacy there. So complaints are of fatigue, having medicines to take, and his daughter really is complaining about the safety of his choice of living alone. He is not particularly complaining about that. You see in his chart that he has a list of medical problems, including probable Alzheimer's disease, congestive heart failure, arthritis and osteoporosis, insomnia, type 2 diabetes, and prostatic hyperplasia. Very, very common conditions in the older adult population, and often that are coincident, related or unrelated to each other. On physical examination, his blood pressure is low or low normal. His physical exam is rather unremarkable. He has a mini mental state exam, which assesses his cognition at the moment, which has declined from 6 months ago. Now 23 was 25. We often use a cutoff as 26 to indicate that there is some cognitive disability. And he sort of has an antalgic gait, limping with some complaint of arthritis in his knee, decline in his sensation and his reflexes distally. What is missing from this exam is a pain scale reading and his weight, both of which are also important in your initial assessment. On laboratory testing, his diabetes reflects very tight control, 6.8%, lower than it had been 3 months prior. His list, again, very tightly controlled within the guidelines that are nationally established for diabetic hypertensive. Total 180, LDL is 70, below our cutoff of 100 by a good margin. His triglycerides are slightly elevated. He had a cardiogram a year ago and has slightly reduced systolic function. His creatinine clearance is not presented here, but could be calculated from his BUN and creatinine, which indicate renal insufficiency, and his glucose that morning is 100. So then, in his medical record reflects, or his care plan that's been provided to him reflects the approach of treating each of these conditions individually. He's on a number of medications, several of which are a couple of times a day. In addition, he has other interventions and then periodic medical interventions according to guidelines. And at first glance, this looks quite overwhelming, but second and third glance, it remains quite overwhelming. He is on alendronate. He has to take first thing in the morning for his osteoporosis, not take any other medicine, remain upright with a large glass of water. Then morning with breakfast, he takes a whole number of medications. At dinner, again, a whole number of medications. At bedtime, again, in the evening, some of his medicines. And then due to his complaint of insomnia, he's been taking a sleep aid at 11 p.m. He's following a specific diet. He's been instructed to exercise every day, and he's told that he should check his finger stick 3 times a day to assess diabetic control. And he has in the past received new vaccines, but comes in for flu vaccines each fall, has diabetic assessments of his foot, his finger sticks, and laboratory testing. Because he's a statin, he gets LFTs regularly, and his cholesterol, and he has other measures for his diabetes and hypertension. Had his bone density followed regularly since he's on alendronate, and he's been instructed in terms of footwear and foot care with regard to his diabetes. Each of the recommendations had come from specific guidelines for each of those diseases. He takes his morning medicines, but after that, he really forgets his evening medicines. He finds he falls asleep in front of the television at night, and he's just too tired. So he really takes his 5 p.m. dinner medicines or his 7 p.m. medicines, and he takes the sleep aid if he finds he can't fall asleep at night. He's checking his finger stick glucoses. It hurts. He's been doing this for many years, and he no longer wants to do it. His diet has become uncertain. He doesn't quite remember what he's eaten. Report to you in his interview. And it's not clear if he's exercising or leaving home or not. But this treatment plan is becoming rather overwhelming for the patient and also, frankly, for the provider of this 87-year-old.
Okay, I'm back on, and we'll walk through the patient preferences and how to incorporate those into more comfortable being a patient about their preferences and using them to drive a lot of our decisions, especially in situations that we call preference-sensitive conditions or preference-sensitive situations. So what we do know from a pretty exhaustive search of the literature and the guiding principles document is that older adults with multimorbidity can evaluate choices and prioritize preferences for care. So when we're scratching our heads as clinicians, or when we're flipping through published guidelines and saying, oh, God, how can we possibly make an organized, thoughtful recommendation because there's so much conflicting, those are definitely times when we should pull the patient and their families into the discussion and say, we can go their way on this. The recommendation for this condition kind of compromises the recommendation for that condition. How do you feel about those conflicting recommendations? What is most important to you? So when we know decisions have this preference-sensitive situation, there's more than one reasonable treatment option. There's not a wrong answer. Patients and their families need to know that you don't have to do this to achieve A1C like this, or you don't have to achieve this LDL like this, or a weight of that, or take this medication at 10 o'clock at night, if that in fact conflicts with what you would prefer to do. Many times we don't really even know the lifelong effect of chronic disease management as it would apply to that patient. So we're stretching what we know, or maybe even applying what we don't know to a patient's recommendation, and patients need to know that, and that going against that, what would appear to be going against a published recommendation, it's consistent with the patient's preferences, is certainly okay. Choices about treatment or interventions with important risks or uncertain benefits, we need to be candid about that. When we know something is in the patient's best interest and there's not much going against it, that's fine to push ahead with that recommendation strongly. But when we don't know that, we need to be very open about that. So we need to recognize when those patient preference-sensitive decisions. And I would recommend in the next 2 or 3 days, when you're dealing with an older person, because you'll deal with probably later today older people with multiple chronic conditions, and you wonder what's the best thing to do, and to pause at that time and ask the person what they think about that decision themselves. And one thing one caveat to that suggestion or that guiding principle is that we clinicians need to be responsible in making sure that the older adult is as adequately informed as possible. And sometimes that means we need to ourselves go to the literature, go to the website, or go to UpToDate to make sure that we know where the evidence of harms and benefits really exists, and where there is no evidence, and to be candid with that information, and to be open when the evidence base may not be sufficient. Take a strongly worded recommendation about an A1C level in an 82-year-old person, for example, who also has kind of heart failure and arthritis and COPD. May not be evidence to say you should do this or you should do that. And on this next slide, we're going to transition back to the case.
So the patient and his children are queried about the number of conditions he has, the medications he takes, his life, and they together express the desire that he wants to remain alive. He wants to optimize the quality of his life. What it means in terms of his medical care, we have to parse out. They clearly prioritize reducing out-of-pocket expenses in terms of his medical and care in general. And he expresses that he wants to remain safely in his home. He does not want to move to a facility. The balance of what is safe is often a conversation that comes up in the care of older adults, and the priority of safety versus remaining at home is one that you often have to investigate in great detail.
So the next step or guiding principle to touch on and to think about in the care of people that Dr. Jacobs is presenting, examine the applicability and quality of the evidence. This is shocking, actually. When you actually go to the literature and see precisely how studies apply or don't apply to the specific patient you're managing. So the case that Dr. Jacobs is presenting, it's pretty certain that many of the guidelines, the evidence that were used to create those guidelines, did not directly enroll and evaluate patients like the one that's being presented. So the applicability and the quality of the evidence is certainly far from, well, the guideline was created, and it was an evidence-based guideline, so therefore it's reliable. That's not the case almost the majority of the time. Also, it's important to note the relevance of the outcomes. So the outcomes that were measured in studies that frequently are cited or inform guidelines may be the same outcomes that are important or the ones that you're striving to achieve in your particular patient. So to have a reasonable familiarity with the outcomes that were sought and used to create and to support a guideline recommendation. Evaluate harms and burdens. We frequently cite, and this is enlightening for me as participating in this guiding principles work group, frequently cite and talk about the efficacy and the likelihood of getting benefit from interventions, but something that's often overlooked or at least underreported is the likelihood of burden or likelihood of harm. And those really should be considered and discussed in a balanced way, that sure could achieve certain outcome of benefit, but you need to also be aware of and share the likelihood of a certain harm and the likelihood of having a toxicity. If the relative likelihood of having that is comparable to the likelihood of benefit, that's important for us to be aware of and to share with patients. Also to know about the likelihood of interactions. If your bisphosphonate is indicated for the treatment of osteoporosis in this gentleman, for example, is likely to interact and cause a high likelihood to cause a side effect, a GI side effect that he doesn't want, that needs to be shared as well. We also need to talk about and think about evidence as it pertains to absolute risk reduction as opposed to relative risk reduction. Frequently, as you would expect, the literature cites the percent decrease or the percent increase of a desired or undesired outcome. When in fact, if the base risk of having that condition is relatively low, those relative risk reductions become less significant and much less important to a patient and their family when reported like that. So a 50% risk reduction, it translates only into a absolute risk reduction of 5% to 2.5%, which is fairly trivial or maybe fairly trivial in the life of a patient. That's very important to present in that way so that patients and their families can understand, and we as clinicians can understand that different way of looking at it. And that's frequently the case in the literature is reported. We also need to think about the horizon to benefit. The data may show an important benefit to an intervention, but it may take 18 months, 2 years, 3 years, 5 years to achieve that important desirable benefit. And that may be too deferred or too long benefit to achieve for that patient and the family to think is important. So with that, we'll be back to the case. Let me click here.
So, starting with diabetes, which is a very highly prevalent condition, certainly in my patients, and I'll assume in your patients and in older adults in general. Great push in the last few decades to attain tight glycemic control in the hopes that we would reduce cardiovascular outcomes. I think now there has been a push against that in terms of the harms of tight glycemic control in older adults. American Geriatrics Society has come out with some recommendations regarding this, and there's a real question, particularly in this patient, but I think you should think about in all of your patients, is the harm of tight glycemic control, that of causing hypoglycemia, more harm than benefit in somebody who has marginal cognition to start with, or even those patients who don't. Killing brain cells may be worse than the harm of some hyperglycemia for a downstream benefit in preventing cardiovascular disease. So that's something that we have to weigh very carefully in our older diabetics. The time for benefit for reduction in cardiovascular outcomes is different in each individual. If they have other morbidities, it may be more serious. If they've had a prior MI or stroke, it may be shorter. If they've never had evidence of cardiovascular disease, it may be more attenuated. Osteoporosis. So bisphosphonates, as we heard, have impressive relative risk reduction for fracture of 50%. However, the actual risk reduction is 1.2% in 3 years. Patient is 87. The question is it continue treatment with the bisphosphonate for this potential benefit within 3 years when it's an extra task for him to take this medicine by itself, to wait the time, and again, he has some cognitive difficulty. We're not even certain if he takes the medication correctly. So these are just 2 examples from our case that we have to go back and weigh the benefits versus the potential harms and his preferences for care. and these are ones that come up quite frequently and would look different in a different patient.
The next guiding principle that we wanted to touch on is the issue of evaluating, communicating, and incorporating prognosis into the care of multimorbidity older adults. So the justification for including that in the guiding principles was that it's really necessary. We don't have a denominator or a background context for how to assess risks, burdens, and benefits for any treatments if we don't put it in the context of what that person's likelihood of living is long or having an opportunity to benefit from something that has at least some degree of burden to it. It's important to also emphasize that this establishing prognosis informs but does not dictate clinical management decisions within the context of preferences. It's something to use, and I think very relevant, tangible. Now, it does require a skill set, no question, and we have people working on that skill set and how best to get information about prognosis and tactfully and skillfully sharing that with patients and families to guide more appropriate decisions. It is also not just mortality, although mortality is the one that has the most information available and accessible to clinicians. But what's the likelihood of having a stroke, for example, from atrial fibrillation? Other issues that are time sensitive. If you treat a person with a certain intervention or manage them a certain way, what's the likelihood of them benefiting from that and the time window that they have? So as far as for clinicians, it allows us to assist the clinical question in a way that the patient can understand, determine the outcome being predicted, the likelihood of having, as Dr. Jacobs pointed out, the two examples she gave in the case, diabetes and osteoporosis. What are we trying to achieve by optimal management of those two conditions? Well, what's the likelihood of them not having a complication from their diabetes from this point moving forward? Their eyes, their nerves, their kidneys. What's the likelihood of them having a better outcome in those adverse by having better control or not better control by diabetes numbers? So, and similarly with the osteoporosis. We have to select a prognosis measurement, recognizing the strengths and weaknesses of that measure. We're going to talk about that and give you, in fact, it's on this slide right here, estimating prognosis. You can go to researched, expert-reviewed websites, the prognosis.org. We would encourage you to visit that if you haven't already, review its contents, and to use it in your clinical decision-making. That's www.eprognosis.org, and it will give you easy-to-use prognostic instruments to use in your to integrate into your decision making with your patients. This example, this is one of the prognostic tools that is used on that website, but it will give you an example, and I'll borrow from Dr. Jacobs' case. That's the blue arrow. But I'll walk you through this diagram, this graph. The tool, which is developed in a population of frail older adults, quantifies in a very robust research methodology way the characteristics of older people in this population that are associated with a higher risk of mortality. And they also use time to that outcome of death as a predictor. So you can see that if you go to that reference, that if certain number of mortality-driven traits exist, more of them, the greater likelihood of death at 2 years, 3 years, 4 years, 5 years. and the mortality curves are different on the number of outcome patient characteristics they have. So in this particular individual, he received 2 points for being male, 3 points for being over age 85, and 3 points for having congestive heart failure. So his life expectancy is with the blue arrow, about 2 years. So the average person like him will be dead in 2 years. Now, of course, there's people who will live longer and there are people who will live shorter, but on average, people like him will not survive past 2 years. And so how to use the information and discuss it with him and his family is your own technique and skill set, but we believe, and the guiding principles support, use that information in your conversations to make more informed and guided decisions about multimorbid older adults with chronic conditions, with multiple chronic conditions. The next slide is touching on optimizing therapies and care plans. So this really gets at how complex the situation is when people have multiple conditions and there's lots of indications for interventions, and how do you optimize that and translate that into a care plan. The thing that we need to be comfortable with as clinicians, and I know we all are on this phone call, is that having that dialogue with the potential harms of polypharmacy, and I think realizing that even though there are probably good indications for all the treatments in someone who has 24 recommended medications, that's unreasonable to expect and probably unsafe for an older person to take that number of medications, even though their conditions might deem it appropriate by guideline recommendations. So therefore, having that conversation about the complexity of it and using to prioritize treatments and interventions to optimize adherence to the most essential things. So reflecting back on the whole issue of patient preferences, time prognosis, and using that to optimize adherence is really important. And conversely is what I should say rather, is we need to avoid therapeutic emissions and reduce potentially harmful or non-beneficial treatments. So it can actually go both ways. We primarily are thinking about using too many interventions, but by doing a systematic review, we might find ourselves pulling in a treatment that's actually more appropriate for that individual that has been overlooked, and reducing the number of treatments that have been included that may not be as important to that individual. So back to the case.
This patient may have been followed for a very long time, and maybe these treatments were really quite important when he was in his 70s, or maybe even his early 80s, where he had a longer prognosis. So the intent of preventing long-term sequelae of diabetes and osteoporosis were relevant. And over time, following guidelines, his medical regimen grew and grew. But now, with the visit, we stopped and we thought, what's going on with our patient? We learned that he has preferences for living at home, despite cognitive disabilities that we've assessed. We understand that the costs of care are important to him, and we also assessed his prognosis on average to be about 2 years. So with that information in mind, we come back to look at his treatments. We've been aggressively treating his diabetes with a sulfonylurea and metformin at the hemoglobin A1C that one could proudly report to be 6.8 as being controlled, but on further thought, we wonder if it's really important at this point to control his diabetes. The harm for hypoglycemia may be greater than the potential benefit if his prognosis is more limited. Also, with declining renal function, we start to question whether we should really be treating him with both glyburide and metformin. He complains of fatigue, maybe it's hypoglycemia, or maybe it's an adverse effect of his beta blocker and the simvastatin. Cognitive difficulties, and there's a significant literature suggesting that perhaps sleep aids or anti-anxiety medications or other psychotropic medications have an impact on cognition. His cognition is also impacted by episodes of hypoglycemia. I don't know. Evidence of renal dysfunction, and it really calls into question at this point, again, whether the oral hypoglycemics are appropriate, but also whether we should continue the alendronate given the more limited prognosis. So we look at medications sort of stacked up and in green his problems, and we you can go on to the next slide, trying to think about how to streamline this care plan so that he can remain at home and can manage these medications despite his limitations. And we start to make a list of medications that we might be able to cut back, perhaps stop over time, and medications that we could potentially stop right away that would have no adverse effect by stopping them immediately. Metoprolol, we wouldn't want to stop abruptly. We probably still need to control his blood pressure, and we don't want rebound hypertension. And we don't know what's going to happen in terms of his sleep, so we have to go a little more cautiously with his sleep aid. But his prognosis and looking at the literature, there may be limited benefit from the medications for improvement in his cognitive status. Certainly the oral hypoglycemics, he's tightly controlled. We could stop the finger sticks. He's already stopped doing them. And probably can stop his oral statin given his prognosis and his current lack of cardiovascular disease in his problem list with the alendronate. We simplify also his regimen, trying to give all the medications at one time so that perhaps with the use of a pill box or a reminder or some other device, we could improve his adherence to the medication. So we identified multiple issues in the care plan. We don't want to overwhelm everyone. We might want to do one or two changes at a time, or perhaps we want to do more. We have to clearly outline this and get agreement with the parent and the daughter and explain our rationale. He's been taking these pills for diabetes for a very long time, and he knows it's a serious condition. Why now that we want to stop these medications?
So we'll switch to the final, I believe, guiding principle, which is probably intuitive to many of the clinicians, and so to outline it as a guiding principle, I think is a natural summary of what we've discussed thus far, and that's the balancing of benefits and harms. So as an example of when considering diabetes, weigh the preferences, as Dr. Jacobs pointed out in her case that she presented, benefits and harms of glycemic control, prognosis and outcomes that are relevant, and harms of tight control. Those are all things that would clearly make sense in this patient and would be an important part of managing all patients with multimorbidity. So Dr. Jacobs really nicely summarized this, and I think that the priorities for this patient and the discussion, I'm sure, would or did occur and will occur for similar patients were very much in line with these summary points that would be discussed with the patient and their family. We want to share with you some important, there are tools that people can use that are included in the reference that we have cited at the end of this presentation. Ways to evaluate treatment complexity for your benefit as clinician, for our own benefit as clinicians, but also a way to illustrate to patients and families the complexity of what a particular patient's clinical situation is. There are pharmacologic and non-pharmacologic aspects of complexity, and I think Dr. Jacobs' summary of that in the large, complicated case at the beginning showed that there are, when you really adhere to recommended guidelines, many of the aspects or components are pharmacologic, but many of them are non-pharmacologic, which are incorporated. There are clinician support tools. I already talked about ePrognosis, which I think you'll find, if you've already begun using it, find it very helpful to you in your practice. The whole idea of time to benefit, there are in particular studies that give you survival curves, Kaplan-Meier curves, time to benefit curves. Those are very important to be aware of and to use in your discussions with patients and their families, and to use as indicators for discontinuation of therapy when therapies, or also when therapy should not be initiated to begin with. The complexity of this.
So I was going to actually comment on this as well. So there are a lot of aspects to this case that we did not touch on. Some of the guidelines, such as giving flu vaccines, still benefit for this patient and should be tightly adhered to. There are aspects of care that we didn't touch on, but it's really important to sort of have an overview of all of the tasks that need to be done in the old adults, and it is perhaps overwhelming for each of you as a clinician in an FQHC to do this in every older adult, but in general, you're often working with a team, and if you divide up the tasks, it may be that other members of your team can participate in the evaluation of older adults and provide some of this data. It's important to review the past year's medical record to see where the patient is now and where they've come from. Our patient might have lost weight. We saw that his glycemic control improved. Maybe it's from weight loss, or maybe it's from inappropriate adherence with his medications, or maybe it's from his decline in renal function. It's important to review all current medications, and this includes over-the-counter medications, which patients often don't report unless they're elicited. And the highlights of those two may be that staff can review and give you sort of cover sheet with your older patients. These are the current medicines. This is the highlights of the previous year. You need to sit and talk with your patient, as we've outlined, about what their preferences are for care and what their complaints are. And they may have no complaints in the areas that you're concerned about, but they may have complaints about their health in other venues. Obviously, you need to do a physical exam, but as part of that exam, you also need to assess cognition in older adults. You need to assess function. So it's not only the traditional medical assessment, but cognitive and functional assessment are critical pieces that drive your treatment plan. And in talking with your patient, you also need to address the fact that he's starting to demonstrate some cognitive disability. He's appointed his daughter as the proxy, and you really need to discuss his care with his daughter if he's willing. And it's a very important step because you're laying the groundwork for future conversations. Laboratory testing, again, can have both benefit and harm. If you win the test, you probably want to act on it. And the question is, do you want to know? And what will be your action in terms of doing laboratory testing? It's important, as you've heard, to assess prognosis. That has to be after you've gathered all of these other pieces of information, since the prognosis tools require patient characteristics to assess prognosis. You need to discuss the options of care with the patient. That says 5 to 15 minutes, but often that conversation can be more prolonged. And finally, you need some tool for help the patient know what to take, what you're stopping, what's the time frame. If you're using an electronic medical record, perhaps there's a patient information sheet that's printed in the end. Perhaps you have a standard chart for the medications. With patients, I use a standard list, and we look at that list every time. I ask them also to bring the pills every time, and I look at the list and I point to the bottle. I reinforce it because there's often a great deal of confusion as to the medication names on the list and what's written on the bottle and whether it's the same thing. So you need tools for helping with the medication discussion, and your team members can help you with this, the nursing staff, etc. So care of this older adult is complex. Their medical conditions are complex, and they may take a good deal longer than the other patients in your panel. And it's important to figure out who to do these tasks and how to parse it out in a standardized fashion so that you can use your time most effectively with the patient.
So this is a summary of what we've discussed today, then we're going to open it up for the Q&A. We realized, Dr. Jacobs and I talked a great deal about this in preparation, about the complexity of this in a very busy, high priority practice. So we know that there will be practice adjustments needed, tools, some of which we mentioned, but others that either will need to be accessed or even developed to help us as clinicians. The multimorbidity focused research, which is growing, believe it or not, but will continue to grow and is necessary. Healthcare redesign, so that including reimbursement, but other ways to facilitate practice management within FQHC and models. As far as training and workforce strategies, you in your own practices, specifically strategies, some of which Dr. Jacobs talked about on the most recent, the last slide, how to alter how your teams approach the management of these types of folks in the day-to-day care. A lot of stuff to discuss and talk about, but we'd like to open it up for Q&A at this point.
Hi, and just to let you know, like Dr. McNabney said, it's open for questions and answers. You can either type in the Q&A window or the chat window, and I just posted a question, so Dr. McNabney or Dr. Jacobs, whoever answers it, just make sure to read it first.
I try to start with this. So the question was, when focusing on patient preferences, how do you handle a situation where the patient and caregiver have conflicting views about what is most important for patient safety, I think, and quality of life? Well, this is a difficult but very difficult area. I think patient preferences are extremely important, but patient preference can't trump a practicality. One could prefer to do something that is absolutely impossible, and if the patient prefers something, they still can't compel their family member to do something that's impossible. So I think you have to weigh their preference in the context of what is possible. That being said, often preference and safety are in conflict. And I think you have to weigh that, and one way is this throughout life in raising children in the same way. How much freedom do you give a child that's safe? I think the same issue for older adults. And in that way, a patient's preference may trump safety. So if a patient says, I want to remain at home, or recognize that it's unsafe, preference trumps the risk that I'm taking by remaining at home. And in that case, if it's something that is doable, in other words, they have enough resources, et cetera, to be able to remain at home, difference may trump the safety requirement. But this is a very individualized discussion, and there's a back and forth. Dr. McNabney, do you have anything further to add?
No, I think you nailed it. That's great.
And then you can type that one in.
Next, I think you have another question here. When making changes in the patient's care plan, what is the best way to prioritize the 1 to 2 changes you should make at one time? Yeah, that's I frequently, I almost feel sometimes like it's I try not to let it be a random choice for sure, and to try to communicate with the patient and family, if they're inappropriate, that these are what seem to be either most the least risk to stopping or to discontinuing if there seems to be a good reason to stop something. So it could be that the greatest harm to continue something should be driving a discontinuation. It could be that the least risk to the patient to discontinuing something. If all believe that discontinuation of some intervention is appropriate. So in the list that Dr. Jacobs gave, she illustrated ones that we've done immediately and ones that should be done over time. I think explaining to patients and their families that this type of change, whether it be a change in diet or a change in medication or a change in some other aspect of their care, will actually provide immediate symptom relief if there's side effect. If the person is getting bad reflux from their bisphosphonate, and you say if that's a priority to you, that will give you immediate relief. If stopping some medication will give deferred benefit or will not really affect the person until later on, that might be something that you not as big a priority to the person. So I think the likelihood of immediate relief or the minimal impact of the person start to discontinuing it earlier is probably the best.
And I would add, I wouldn't start with something that the patient opposes or has difficulty with because you want the patient's buy-in. So I had a patient in my practice recently who felt as depressed, and I've been trying to get her to consider an antidepressant for a long time. But she also had chronic pain and many other multiple conditions and hypertension. We started with the changes that probably had less of an impact on her life, but ones that she would accept. And if we eventually, building trust, got back to the antidepressant. And I think it took her a year to come around to being willing to try that intervention. But she eventually did because we had built a trust between us. So I think don't start the hardest one because they lose them on the first change. They've been taking this regimen for a long time. Their previous doctor gave it to them. They believe in it. Start with perhaps something that's a big change, but also something that will go smoothly.
Thank you very much for your presentations and for the questions I answered. Just for the participants, I will let you know that made mention to the AJS guiding principles for caring for older adults with multimorbidity. We did email you to that with the other materials. If you don't have that, you can see it at our webpage at americangeriatrics.org/multimorbidity, and you can also get in touch with me if you need that again. Just a reminder that you will need to take a post-test after this in order to receive your CME credit for the presentation, which will include some evaluation questions. As soon as you close out the event, you'll be immediately directed to the post-test page on SurMonkey. If you happen to be viewing the webinar without being signed into the software, I'll send you an email with a link to that. At any point, you can contact me or your staff contact at CHCANYS with any questions or difficulty accessing the post-test. So we want to thank you very much for your participation in today's webinar, and we look forward to your feedback. And thanks to Dr. McNabney and Dr. Jacobs again. Thank you.